Continue with the program. I'm going to ask Dr. Basir to come with me to the panel. Right here. There's a translator over there. And I'm going to ask Dr. Bangalore to come to the panel too, please. So we're going to start this session is the shock team approach. First, we have Dr. Rachna Kataria. She couldn't come today, but she sent us a video. She's presenting the recently published expert consensus in management cardiogenic shock. So,
Hello, everyone. I am Rachna Kataria, and let me start by congratulating Vicente, Guillermo, and the entire TechSalud team for yet another incredible meeting. I am sad I couldn't be there, but really excited that I was invited to speak about ACC's first ever clinical consensus guidance document published in 2025 and written on the topic of evaluation and management of cardiogenic shock. I was a co-author of this document that was chaired by my dear friend, Dr. Shashank Sinha, who is also a fellow cardiogenic shock enthusiast. So let's dive in. What was the rationale for this document? We know that cardiogenic shock is associated with significant morbidity and mortality. But what we are learning is that a large proportion of shock patients are managed at private or community hospitals, with up to 43% of AMI shock patients being managed at low-volume PCI centers. More than 50% of all shock patients that are managed at regional CS centers of excellence are transferred in from hospitals in the community. So early recognition, stabilization, and timely transfer of shock patients is key to improve outcomes, and there is a pressing need for democratizing shock care. There's also a lack of consensus regarding the designation of CS Centers of Excellence. So in order to address some of these unmet needs, the ACC in December 2023 instated the planning committee for this consensus guidance document. And then we, in March of 2024, convened ACC's Heart House Roundtable on this topic. We invited a diverse group of experts from the US, Mexico, Italy, France, and Germany. 33% of the participants were women, and we had a mix of subspecialists, heart failure, interventional cardiology, critical care, but we were also fortunate to be joined by advanced practice providers and pharmacists who brought their perspectives. We identified key areas that we wanted to discuss at this meeting, and those included early identification and management, hemodynamic assessment, pharmacological management, temporary MCS and cardiogenic shock, and finally, critical care management. So based on our discussion, we identified 7 key areas that the document would then focus on, so let's dive in. Starting with the initial evaluation of cardiogenic shock, and I've always believed that that initial evaluation starts with a simple suspicion. If you suspect shock, you'll move on to making a diagnosis. So to help us make that initial diagnosis of cardiogenic shock, we devised a mnemonic, and it's called Suspect Shock. The components of this mnemonic are simple: signs and symptoms, urine output, sustained hypotension, markers of perfusion, EKG or echocardiogram, congestion, and finally triage. So first of all, majority of the components of this mnemonic are easily obtainable. And then we also included triage in this mnemonic because we want you to start thinking triage or transfer as soon as you've made a diagnosis of cardiogenic shock. When you've made the diagnosis, you are also now able to classify your patient's shock severity using the SCAI shock classification or CSWG's modification of the SCAI shock classification. Speaking of triaging or transferring your patient in cardiogenic shock, key considerations that you need to think of are: what is your patient's SCAI shock severity? What's their shock classification? Do they need escalation to temporary MCS? Is there an absolute contraindication to escalating care? Does the institution you're at have the resources to support the given patient? And if not, is your patient hemodynamically stable for transfer to another institution? We also provide a schema for classification of CS centers based on resource availability. So for example, a level 1 center is a center that has the full gamut of cardiogenic shock resources, including infrastructure, personnel, full gamut of temporary MCS. They may also have LVAD and transplant capabilities. In contrast, a level 3 center may only be able to make the initial suspicion and diagnosis of cardiogenic shock. Maybe they'll be able to provide initial stabilization with a drug, but then they might need help from a level 2 or level 1 center to take care of this patient. Another component of resource infrastructure of a cardiogenic shock center is its shock team. We know that interdisciplinary shock team-based management of cardiogenic shock improves outcomes. Composition of a shock team can be very different from one center to another center, but the role of a shock team is to help identify the right patient for the right therapy at the right time. Having a shock team also helps get the ball rolling, even if that means you need to transfer your patient to another center of care. Moving on to the management of cardiogenic shock, let's first talk about hemodynamic assessment. So as we just discussed, the initial suspicion and diagnosis does not require invasive hemodynamics, but once you've made the initial diagnosis of cardiogenic shock and you've classified your patient's shock severity, you might use a PA catheter to help guide selection and escalation of drug or device therapy. Also, if your patient's not responding to your initial therapy, typically a drug, then you would use a right heart catheterization and the numbers obtained from it to better understand your patient's hemodynamics to inform further management. A complete hemodynamic assessment has been shown to improve outcomes in cardiogenic shock, and we're all awaiting the results of the PAX trial, which should shed more light on the use of PA catheters in cardiogenic shock. Moving on to pharmacological management of cardiogenic shock, so the goals of pharmacological therapy are decongestion, optimizing cardiac output, and improving end organ perfusion. When it comes to decongestion, IV diuretics, renal replacement therapy is what we have right now. That might change. But as far as hypoperfusion, we have several drugs that we can pick from, and all of us in this room probably have our favorite drug of choice that we tend to use. In this guidance document, we agree that Levophed is probably the reasonable first choice for most cardiogenic shock patients, and if you look at the table on the right, norepinephrine or Levophed is an inopressor, so it provides inotropy but also pressure effect. And it's typically available at most level 2 or 3 centers, but in the absence of that drug, we have all, I think, received transfers of patients who are not on Levophed, but just the other drug that was available at the level 2 or 3 center. As far as temporary MCS and cardiogenic shock, data is limited. Most of the RCTs have focused on AMI shock, STEMI shock. There's been some variability in patient selection, in the timing of temporary MCS support, and there isn't really any head-to-head comparison that we could utilize in this space. When you're thinking of using temporary MCS in your shock patient, if you can remind yourself that your goal is to optimize your patient's cardiac output while minimizing the complications, then that is key. That is important. Routine use of temporary MCS in all cardiogenic shock patients is strongly discouraged because that just sets you up for failure. Temporary MCS and AMI shock, so we provide a guidance for utilizing temporary MCS or combination of temporary MCS and AMI shock with the little data that we have available. At the time of this writing, we did have the results of the DanGer Shock trial available to us, which is, of course, a landmark trial in the space of our AMI cardiogenic shock. And based on that, we do recommend escalating to microaxial flow pump in select patients with STEMI shock who have LV predominant shock with clinical hypoperfusion and or hemodynamic worsening. When it comes to heart failure shock, there's even less data in this space. So we appreciate the paucity of robust RCT data at the time of this writing. We also didn't have the results of the ALL-SHOCK 2 trial, which have not been addressed in the document. Moving on to critical care management of cardiogenic shock, if you think, so this is when your patient's out of the cath lab, has gotten their device, or is on a drug and is in the CICU. Key components of critical care of a patient in cardiogenic shock are reassessment, treatment of reversible causes, mitigation of complications that may arise from MCS or just the critical nature of the disease, management of end organ injury, de-escalation of invasive therapies, and coordinating interdisciplinary care. Reassessment is key because cardiogenic shock is dynamic. Complications in cardiogenic shock may arise from the critical care nature of cardiogenic shock, and they may be systemic. On the left are some examples of complications associated with the different organ systems. And on the right is a table that alludes measures to reduce complications that are associated with temporary MCS. So that involves serial examination of vascular access sites, avoiding excess anticoagulation, examining the sites after mobilizing the patients, so on and so forth. We then move on to speak about mechanical ventilation in patients with cardiogenic shock. Now, a lot of our patients in cardiogenic shock will require some form of positive pressure ventilation. PEEP does affect preload and afterload, and it's important to understand that when you have a patient who is in RV failure or a preload dependent state, moderate to high PEEP will decrease their RV cardiac output. In contrast, when you have a patient in LV failure or an afterload dependent state, PEEP will improve their LV cardiac output. So in this document, we provide a strategy for initial ventilation of patient in cardiogenic shock and then for adjustment of PEEP as you go through the patient's course in the disease. Weaning temporary MCS in patients with cardiogenic shock is an interdisciplinary decision. It is no one person's decision, it is a team sport. Readiness for weaning should be assessed every single day, and it depends on, or the metrics that you're looking for are hemodynamic stability, whether the patient's needing vasoactive agents, what is their volume status, and has there been any improvement in the underlying cause of shock. You also want to identify exit strategies, which is important, whether it's going to be native heart recovery or replacement with a VAD or a transplant. And then weaning should always be stepwise. Lastly, we provide summary graphics that capture the golden hour of acute shock. Time is muscle and SCIB is bad. It all begins with a suspicion of shock, so you should suspect, stratify, start therapy, and activate your shock team as rapidly as possible. And then once you've activated your shock team, you still have bigger decisions to make. Does the patient need to be transferred? Does the patient need to go to the cath lab? Does the patient need to go to the CICU? Is this patient stable enough that you can simply reassess them? Or does this patient need escalation of temporary MCS? Is this patient now optimized as far as therapy? Do they need any personalized interventions depending on the cause of shock? What's their exit strategy going to be, and is that changing based on the trajectory? And then, of course, involving palliative care. So I'll end by stating some of the key takeaways from this document. Cardiogenic shock is heterogeneous, it's multifactorial, and it's dynamic. You must stage the shock. Early recognition of shock is critical. Invasive hemodynamics could help you in guiding your patient's management. End organ perfusion is the name of the game. Think about temporary MCS and think early. Reassess, reassess, reassess. Care of cardiogenic shock is a team-based sport. Prevention, recognition, and management of complications of therapy is key. Palliative care options are essential. So with that, thank you again for the invitation, and I hope that you have a wonderful discussion at the end of this session. Thank you.
Now we're going to continue with Dr. Basir. He needs no introduction. He's one of the experts in field. He's coming from Henry Ford Hospital in Detroit. He's a good friend, and he's going to present to us what's the need of, why do we need a directed cardiogenic shock initiative? So, Basir.
So, Vicente, thank you for having me, and it's always great to be in such a beautiful venue with familiar people and friends. So, I think Jacob set the stage for us nicely with the data that's been there, and particularly from DanGer. And I'm going to talk a little bit more on the practical aspects of why creating a cardiogenic shock initiative is helpful to be able to improve outcomes in our patients. So we saw from Jacob that there was a 12.7% reduction in absolute mortality in patients who were treated with Impella in STEMI cardiogenic shock. This resulted in a number needed to treat of only 8 patients. And he also showed nicely how at the 10-year mark that patients had a sustained benefit, and what it translated into was around 2-year improved survival for the majority of patients, around 600 days. And this led to guideline changes within the AHA and ACC for patients in STEMI and cardiogenic shock to be treated with an Impella device at the onset of their cardiogenic shock. So how can you take the findings from DanGer and incorporate them into your own institutions? And it's not just specifically on MCS and Impella use, but really what are the keys to successful patient management in taking care of patients with cardiogenic shock? And I do firmly believe that protocolizing complex scenarios makes things easier for people to be able to replicate these critical situations. And ultimately, it boils down to about 5 practical steps: decreasing delays in care, whether that's door to support time, providing equitable care for patients, weaning off pressors, providing peripheral perfusion, and mitigating complications. So I'll start by saying that, one of the ways to practically, one of the major ways that a protocol will help is to be able to create a system of care in your institution to be able to decrease these delays. And the Shock Working Group showed nicely the importance of the first 24 hours of therapy, and they've also subsequently shown data on the first 6 hours of therapy, but really every hour is critically important within these patients. On the right-hand side of your screen is just data that we've collected through the R3 and NCSI pooled analysis that will be presented next month at TCT, which showed that even within the first hour of getting a support device, patients who were treated early had significantly better outcomes, not just within the hospital or at 30 days, but it was sustained benefit out to 1 year. And a lot's been made about the discrepancies that we've seen within the DanGer Shock study as it relates to particularly women and their outcomes, as well as the impact of age on the outcomes of patients. And one of the things that Jacob and the DanGer team showed very nicely is that the driving force for a lot of that, a lot of those outcomes, we hypothesize is because of a delay in care and treatment. And so if we take the NCSI data, which had 400 patients treated with Impella in AMI cardiogenic shock, you see that when we implemented a shock protocol, that we actually didn't have any difference in outcomes between men and women, and patients benefited equally because they were given therapy. And I think that's ultimately the key. The other thing about protocolizing care and the early delivery of hemodynamic support devices is it allows for weaning of vasopressors and inotropes. And Rachna did a great job in explaining, which agents are available and what her recommendation and the ACC's guideline recommendations were for the use of those agents. But it is also important to realize that those agents are increasing your myocardial oxygen consumption and demand at that time when you're in a very vulnerable position. And so using these agents can be actually harmful. And so being able to wean off pressors is a really important aspect of care. And these are things that you can actually think of in low resource environments as well, is that are we actually protocolizing our weaning of vasopressors and inotropes, or are we just putting somebody on 5 mics of norepinephrine and 5 mics of dobutamine and then just waiting till the next day to be able to decide on medical titration? These are things that can actually potentially improve the recovery of these patients. And then when you protocolize care in this way, you are able to actually restore perfusion in the fastest state as possible. And this was shown in DanGer, where the Impella arm, compared to the standard of care arm, cleared their lactate faster within the first 24 hours. Similarly, in NCSI, we found that patients were able to clear their lactate, and that was a very prognostic marker of their overall survival. And ultimately, what that led to is the SKY Door to Lactate Clearance Initiative, and me and Sandeep were honored to be a part of it as co-authors of this. But I think it is really an important initiative, particularly in low-income clinical care settings. And the reason for that is because when we talk about what opportunities you have to be able to reverse early cardiogenic shock to be able to not require a hemodynamic support device, being able to recognize it is one of the most important aspects. And it goes beyond just clinical symptoms, but having an objective biomarker to be able to quantify, is this patient getting better or are they getting worse? And so within this initiative, basically it's calling for people to get lactates into their shock protocols, so that if you have heart failure shock or AMI shock, that you actually draw lactate levels every 2 to 3 hours. You follow those levels. If you know the lactate is normal or clearing, then you know that your patient's in generally good shape. And if you realize that your lactate is climbing or rising, it's not even clearing, then those are patients that potentially need a little bit more therapy and a little bit more help. And a lot of early interventions can then replace the need for mechanical circulatory support down the line. Now, all of this data that we've talked about so far, at least from my standpoint, and what was studied in DanGer, is all related to the Impella CP. But we know that we have a device available that provides more robust hemodynamic support, but most importantly comes with a lot less complications. And so we can imagine the benefits of being able to use a device that's more powerful with less complications after we learned from Jacob and the DanGer team what the impact of an Impella CP can be on AMI and cardiogenic shock outcomes. And I'm not going to talk about next generation devices now. I'm going to save that talk for tomorrow. But it is a really, really exciting time to be in the shock space, because there's lots of new toys that are available to us to be able to use. And I think, when we talk about protocolizing care, a lot of the discussion that I've seen has been protocolizing care in the EMS setting, in the cath lab, and a little bit within the ICU setting as well. But really, we have to create best practices bundles and protocolization for each of these steps. And so this is being done concomitantly in the Global Cardiogenic Shock Initiative, as well as in the OASIS AMI Cardiogenic Shock Trial, where we're basically looking at these best practices, the foundation of cardiogenic shock studies so far, and being able to decipher a little bit more about how to decrease complications and therefore magnify the benefits when utilizing hemodynamic support. So to conclude, the DanGer Shock trial demonstrated a survival advantage with Impella that resulted in a Class 2A recommendation, in the ACC-AHA guidelines. The use of a shock protocol provides early treatment to these patients, and it allows for shorter door to support times, being able to wean off vasopressors and inotropes early, and being able to clear your lactate faster. And so if Impella is to be utilized as first line in patients in stage C, D, and E shock, it really needs to be done in a protocolized and systematic way. Thank you so much.
Thank you, Babar. So now I'm going to present the importance of a shock team approach. Okay, so I'm going to present this in Spanish, okay, so everyone can. Entonces, voy a hablar un poco de la importancia de por qué hemos abordado a estos pacientes en equipos de choque y sobre todo cuál ha sido nuestra experiencia en TechSalud desarrollando esta iniciativa. Y yo creo que la mejor forma de hacerlo es presentando un caso. Este es un paciente de 69 años, fumador, con antecedentes de hipertensión, diabetes, dislipidemia, que se presenta a nuestra unidad después de 5 horas de dolor torácico opresivo. Llegó a un hospital de segundo nivel, se evidenció elevación del ST anterior con bloqueo de rama derecha. No tenían sala de hemodinámica cerca, se administró trombolisis con tenecteplase de 50 miligramos, tuvo reperfusión leve, mejoría parcial de la sintomatología, pero se refirió a nuestro centro para angioplastía. Pero durante el traslado el paciente presentó nuevamente dolor torácico, diaforesis, datos de hipoperfusión. e hipotensión. Entonces, cuando llegó a nuestro hospital, hipotenso, 70/50, taquicárdico, con taquipnea de 30 latidos por minuto, saturación limítrofe y con datos clínicos de shock cardiogénico. Inicialmente ahí en emergencias se manejó con vasopresores, inotrópicos y diuréticos. El paciente por el distrés respiratorio se decidió intubar y se activó simultáneamente el equipo de choque. Ya lo he comentado en otras sesiones, pero desde hace un tiempo ya estamos evaluando siempre el lactato en todos los pacientes con infarto en nuestra institución, precisamente para detectar aquellos pacientes que tienen datos de hipoperfusión bioquímica, ¿verdad? Este paciente tenía un lactato de 8.3 en este momento. Esta es la radiografía de tórax, claramente congestivo, un infarto anterior extenso con disfunción ventricular severa. Entonces, medimos la presión teleastólica del ventrículo izquierdo de 36, decidimos hacer una inyección en el acceso vascular del lado derecho, en la arteria femoral común, para asegurarnos de que los accesos eran adecuados para colocar un Impella en este contexto. Y bueno, aquí utilizamos la técnica de single access. Siempre todas nuestras punciones las hacemos ecoguiadas y con control angiográfico. Para los que no estén familiarizados, el single access, la técnica de single access permite que a través del mismo introductor 14 French del Impella CP podamos colocar un introductor 7 French y hacer la misma angioplastía por ese introductor, minimizando riesgo de complicaciones vasculares y teniendo un acceso secundario. El eco es una herramienta fundamental durante la colocación y el posicionamiento, que nosotros ya de forma sistemática siempre lo tenemos. Entonces colocamos al paciente en Impella CP. Esta es la angiografía. Se ve una lesión, árbol coronario severamente calcificado con lesión de tronco distal en bifurcación, lechos distales de muy pobre calibre, y se ve una oclusión de aspecto, si se corre, de aspecto trombótico a nivel del segmento medio de la descente anterior y una lesión ostial de la coronaria derecha, ¿no? Entonces se intentó hacer se hizo un intento de angioplastía a la descente anterior. Con mucha dificultad se logró cruzar una guía, pero el comportamiento de la lesión fue como de una oclusión crónica. Fue imposible pasar balones de bajo perfil, incluso microcatéteres. Entonces, debido a que el paciente estaba bien soportado en ese momento, nosotros hacemos esa evaluación con cateterismo derecho. Es importante conocer los cambios hemodinámicos que estás teniendo después de soportar al paciente, y debido a la complejidad que representaba el hacer una angioplastía o que requeríamos de dispositivos más avanzados en el contexto agudo, y con estos valores hemodinámicos, donde teníamos metas aceptables con un poder cardíaco 0.6, 0.76 y una PAPI de 3, decidimos parar en ese momento, descargar al paciente con Impella y evaluar en un segundo tiempo. Pero las primeras 24 horas fueron difíciles. Tuvimos varias alarmas de succión, mal posicionamiento del dispositivo. Jacob ya lo comentó muy bien en su sesión, que a veces las complicaciones no ocurren en el cath lab, sino ocurren cuando vamos a la terapia intensiva. Y eso fue lo que sucedió, ¿verdad? El paciente era uno el que salió de la sala de hemodinamia y otro el que se comportó en la terapia intensiva. Empezó a tener más requerimiento de vasopresores, acidosis, que no podíamos barrer el lactato. Ya vimos la importancia del tiempo para el aclaramiento del lactato. Datos francos de hemólisis con hematuria franca. Entonces, logramos posicionar de forma adecuada el Impella guiado por eco, logramos tener mejor control del dispositivo, adecuando nuestra necesidad del soporte de acuerdo a los parámetros hemodinámicos, y con eso logramos cierta estabilidad. El paciente pudo mantenerse estable solo con soporte con Impella por 72 horas, pero recordando que aquí en México no tenemos nuestro dispositivo para escalar en este momento, no contamos con el Impella 5.5 cuando vimos este caso. Entonces era una pues es una situación en la que te ves frecuentemente, donde una vez que decides ir con el dispositivo tienes que estar seguro de que vas a tener una estrategia de salida para estos pacientes, en donde el ECMO nos ha ayudado, ¿verdad? En el instituto tienen cierta experiencia con Lava ECMO y bueno, nosotros en su centro también tenemos Centrimac. Entonces, estos fue el tipo de discusiones que se tienen que tener de forma multidisciplinaria para el toma de decisiones y sobre todo con la familia, ¿verdad? Pero fue posible que el paciente mantenerlo estable por 72 horas y después lo transicionamos a balón de contrapulso. Eso es algo que hemos estado haciendo para bien o mal, digo, aquí estarán más expertos, pero hemos desarrollado como esa estandarización de casi siempre transicionamos en la salida del Impella con balón de contrapulso a los pacientes y a veces con un poco de inotrópico. Los parámetros hemodinámicos mejoraron importantemente con el paciente, pudimos barrer lactato y luego decidimos llevar, se comentó el caso con el equipo, decidimos volver a llevar en un segundo tiempo a la evaluación de del árbol coronario en este paciente. Y yo creo que aquí algo destacable es que la reevaluación de la anatomía coronaria en el contexto más estable te puede contribuir a tomar decisiones distintas, ¿verdad? Porque a veces en el contexto de choque, vasopresores muy altos, el grado de vasoconstricción que pueden presentar los pacientes pues es mayor y la anatomía puede no ser percibida de igual manera. Entonces, en este momento el paciente estaba estable, ya tenemos un poco más de conocimiento sobre los lechos distales, no teníamos claridad sobre cuál iba a ser la nueva estrategia de revascularización, el paciente estuvo más estable, pero seguíamos sin revascularizar. Decidimos una resonancia para ver viabilidad, en donde pues, se mostró un infarto transmural de la pared anterior con algunos datos de viabilidad. Sin embargo, la función ventricular baja, ¿no? Cerca del 29%. Se discutió con el Heart Team cuál era la mejor estrategia para revascularizar un paciente con enfermedad multivaso, con un infarto anterior extenso, con transmuralidad del infarto. Y decidimos que el paciente está en buenas condiciones para ser evaluado por cirugía. El paciente se operó, se le colocaron 4 puentes, sí se revascularizó como quiera la descendente anterior. Y tuvo buena evolución después de eso, ¿verdad? Y en el seguimiento a 3 meses, el paciente no ha tenido hospitalizaciones por falla cardíaca, tiene una función ventricular de 35% y tiene una clase funcional NIHA2 y está constantemente en rehabilitación. Entonces, Rachna ya lo ejemplificó perfecto, lo que era inicialmente el Golden Day y luego se ha vuelto como el Golden Hour de las decisiones que tomemos desde el inicio van a impactar en el desenlace de nuestros pacientes. Y está claro que el abordar de forma individual a estos pacientes no obtienes buenos resultados, requieres de expertise de diferentes especialistas que estén bajo una misma visión y un mismo objetivo para obtener mejores resultados y sobre todo tomar las mejores decisiones, que sabemos que estos pacientes son sensibles al tiempo y el retrasar un poco la atención puede contribuir a que el desenlace no sea satisfactorio. Y hay que alrededor de la colaboración del equipo de choque existen varias cosas, ¿verdad? Existe la integración como equipo, decisiones con respecto al costo, en cuanto a la calidad, la reproducibilidad de los resultados. Y solo para tener una perspectiva, somos nosotros, somos el Hospital Zambrano Elion en el norte de México, en donde uno de los principales retos iniciales fue establecer un equipo de choque y quién iba a involucrarse en este equipo de choque. Y no solo eso, sino cuáles iban a ser los roles de cada individuo o cada persona en este equipo. Otra parte importante y retadora fue también la educación, educar a residentes, educar a enfermería, educar al personal de emergencias sobre cambiar el paradigma del soporte temprano previo a la angioplastía, utilizando algoritmos de manejo, tomando decisiones guiadas en evaluaciones hemodinámicas invasivas y obviamente con apoyo de expertos. Establecimos un código de choque en nuestra institución Este flyer que ven a su lado derecho está pegado en la sala de emergencias, en la sala de hemodinámica, en la terapia intensiva, en donde estamos constantemente recordando el beneficio de tener un equipo de choque, quién es el equipo de choque, cómo deben de activarlo, para que esté en la mente de la gente, porque a final de cuentas los pacientes no llegan directo al equipo de choque, llegan por emergencias, se colapsan en otras áreas y ellos necesitan activar al equipo. Entonces, el crear esa conciencia, como les comenté, no tenemos disponibilidad de todos los dispositivos, pero ha habido que desarrollar cierto expertise en los dispositivos, no nada más desde el punto de vista de los intervencionistas y los cirujanos, sino también el manejo de enfermería en la terapia intensiva, intensivistas. Y bueno, esto ha sido nuestra experiencia en choque cardiogénico desde que iniciamos el programa, que fue en el 2022. Hemos evaluado una buena cantidad de pacientes, la mayoría se han presentado en estadios avanzados y principalmente de patología isquémica. Y yo creo que este es un dato muy relevante, muy importante de nuestra institución. Nos dimos a la tarea de evaluar cuál era nuestra mortalidad de forma previa al desarrollo del programa de choque, y la mortalidad en shock cardiogénico estaba cercana al 63%. Y desde que desarrollamos el equipo de shock cardiogénico hasta la actualidad hemos visto un cambio en la sobrevida de nuestros pacientes y actualmente tenemos una mortalidad que ha bajado al 25%. Es importante. Entonces, este es un programa que constantemente tenemos que reevaluarnos, tenemos que mejorar y siempre tratar de tener mejor impacto en la calidad de nuestra atención y en nuestros pacientes, pero a veces la dificultad no está en el desarrollar un equipo, sino en mantenerlo, y eso requiere un esfuerzo importante. Y bueno, ya para finalizar, les recomiendo este artículo publicado por Raymond Yaw de New Mexico, en donde pues precisamente se habla de lo que es el protocolo ideal para desarrollar un programa de choque y sobre todo para mantenerlo. Y finalmente, a mí me gusta esta analogía de crear un programa de choque, es como construir una casa, ¿verdad? Necesitas buenas bases, necesitas protocolos para seguir, necesitas el material, ¿verdad?, que es el equipo, pero necesitas también un equipo sólido para llevarlo a cabo, ¿verdad?, como son los intensivistas, expertos en falla cardíaca, enfermería, perfusionistas, incluso la línea de servicio administrativa. Y una vez que construyes eso, ahí es cuando puedes mudarte y empezar a vivir, que es cuando mejoras los outcomes de los pacientes. Y con eso les agradezco mucho su atención. And just to finalize, I will ask Dr. Bangalore to present us the PERTs in the contemporary era.
Thank you very much. And this sets the stage for my talk. I mean, borrowing from STEMI teams to shock teams to heart teams, and let's try to apply that to PE management and look at PE response teams. In terms of PERT, I mean, I'll make a case of why everybody should consider having a PERT team. So let's talk about the rationale for PERT teams, the why. Why should we have a PERT team? Who should be the members of the PERT team? What should be the PERT protocol? Not going into details, but broadly. And which should be the PERT centers and PERT network. You know, we started our PERT team in the middle of the COVID pandemic, but it's been very, very helpful in kind of managing this complex group of patients. So the PERT as a concept was started at MGH. Kenny Rosenfeld there was instrumental in starting this at MGH, and this was in 2010. And this is their first publication in 2013 about PE response team. And you know, just to read out what they started out and where we stand right now, the mission at that time was to advance the diagnosis, treatment, and outcomes of patients with severe PE. The goal was to improve outcomes using a collaborative, multidisciplinary, team-based urgent consult to treat massive and submassive PE. And the functionality was modeled on the rapid response concept, which has been very helpful. It's a multidisciplinary team of experts conveyed via electronic meetings, evaluate and offer full range of available treatments. And then of course, so this is how it started. And so using that framework, let's talk about why do we need a per team approach for the management of PE. We talked earlier today in terms of classification of risk stratification of PE, and we also talked about the guideline recommended therapies. For example, if you have a patient with low risk PE, the guidelines would say you should give anticoagulation alone. The mortality for low risk PE is around 1%. If you have intermediate risk PE, the guidelines again would say anticoagulation alone. The mortality of an intermediate risk PE is 3 to 15%. If you are hemodynamically unstable, it's high risk PE, the guidelines would recommend lytic or advanced therapies. Mortality is around 30%. And this morning, I was also comparing this to ACS equivalents and making a point that intermediate risk PE, where the recommendation is anticoagulation alone, the mortality is 3 to 15%. And if you look at some of the US data for uncomplicated STEMI, the 30-day mortality is less than 3%. So here we have a condition where the mortality is more than an uncomplicated MI, but we are only using anticoagulation alone based on guidelines. And again, unlike MI and STEMI care, there isn't an organized protocol. So I want to make a point that the mortality for acute PE is worse than MI, and current therapies, mainly anticoagulation, are woefully inadequate, and potentially having a team-based approach can be instrumental, as we've seen for other conditions, that we can drive down this mortality further. So the other consideration, one of the things to consider is historically, even in our institution, most of the PEs would go through the pulmonologist. They were the ones who were first responders. They would manage the patient in the ICU or on the floors, etc. So historically, it was considered a pulmonary problem, but we know, as we discussed earlier this morning, that patients with PE rarely die from hypoxia. Our pulmonologists tell us that they can always oxygenate these patients. It's rare. You can have conditions where it's difficult to oxygenate, but it's rare. You can oxygenate them, but the reason they die, as we looked at this before, is this shock spiral. So just like the LV shock, RV shock from a PE is also a spiral. So in other words, it's not a slow decline. Once you go into the spiral, it's a rapid deterioration and leads to obstructive shock and death. And we also talked this morning that we start with an increased RV afterload, increasing RV wall tension, increasing RV oxygen demand, decreasing supply, leading to RV ischemia, decreased RV output, decreased LV preload, and finally low systemic blood pressure and massive shock. So what we were trying to point out there was waiting for the blood pressure to get lower, maybe too late, and we should be identifying phenotypes such as normotensive shock or patients at high risk of shock, so that we can potentially avoid hemodynamic deterioration and massive shock. So the other rule that we discussed this morning was the PE may be acute, but the thrombus is rarely ever acute. So this is some data from our own institution looking at DVTs, and where we showed that majority of the DVT are in an advanced stage of organization. And because of this, advanced therapies, which are independent of anticoagulation and lytic-based mechanism of action, may be important. The bigger problem we have in the PE space is it continues to be a diagnosis problem. So here I have an example. This is Serena Williams. She, after giving birth to her daughter by C-section, Serena Williams was having trouble breathing and immediately assumed that she was having another pulmonary emboli. She was in the hospital. She told a nurse to what she felt, and she asked for a CT scan and a blood thinner, but the nurse suggested the pain medication and left her confused. Finally, when the Doppler ultrasound revealed nothing, she underwent a CT scan which showed several small blood clots in her lungs. So even in a major institution, and even for a person like Serena Williams, clearly PE tends to be missed. And this is where I feel like having a systematic approach can not only improve therapeutic output, but also improve diagnosis of these patients. So the other reason you should consider per team is the risk stratification for PE is evolving. It's still complex and not very well defined. Again, we talked about this in multiple risk scores. We derived and validated the composite pulmonary embolism risk score. There is also the SPSE score. There is a BOVA score. There is the new score. So people can get confused with all of these scores as to figuring out how best to apply these patients for their particular patient. And of course, this recent publication where we showed that CPES score outperforms any other score in predicting PE-related outcomes. And in terms of our per team, we have a unified protocol, so we use CPES for all our triage and risk stratification. So the other reason why we should consider per team is clearly we saw the guidelines and there is no clear algorithm for management, and many are based on consensus. And of course, in terms of therapeutic options, you have anticoagulation alone, you have systemic thrombolytic therapy, you have catheter-based therapies which come in two flavors, either CDT or mechanical thrombectomy, and of course you have surgical thrombectomy. So we have many options, and we have to consider tailoring therapies based on a patient's presentation and needs. The main reason to consider per team is escalation of care and potentially can you improve outcomes. So we asked the questions, do per teams actually improve outcomes? Because one of the things that I get asked is, now you're saying that you want to start another team. I mean, where are the resources and can we justify this? So we looked at this. This was published earlier this year, looking at asking a simple question, do per teams in PE improve outcomes? And this is kind of a summary. So this is a meta-analysis of observational study where we showed that compared to treatment with a per team versus no per team, there is lower all-cause mortality. Interestingly, we also showed that even though there was an increase in advanced therapy utilization, the major or clinically relevant bleeding was significantly lower. We also showed that the hospital length of stay was significantly lower, ICU length of stay was significantly lower with per teams when we compare to no per teams. So we concluded by stating that per team significantly lowered short-term mortality, bleeding-related endpoints, there was higher utilization of advanced therapies, and lower hospital length of stay. And we said PERT should be the standard of care for the management of patients with acute PE. And finally, the other reasons to consider per team is faster dissemination of emerging data implementation of care. I can tell you many a times when we have conversation with our per team, I'm telling the team about nuances of device-based therapies. The pulmonary guys are feeding me information about nuances of management and so forth. So there is a good dissemination of information. In terms of the PE space, there is a lot of randomized trials in the pipeline. Some have been completed, some are in the pipeline. So if you look at intermediate risk PE, there is the PE track trial trying to compare it against anticoagulation alone, the PEERLESS 2 trial comparing it to mechanical thrombectomy to anticoagulation alone. And moving from why to who should be the members of the PERT team, again, depends on your institution. This is a snapshot of who all can be involved. In our case, it's typically the pulmonary critical care guys along with the critical care cardiology and interventional cardiology. We do involve other members of the team as and when needed. For example, if there is a clot in transit across a PFO, we get a CV surgeon on the call. So it really depends on what it should be. I also know of structures where the entire PERT team is only comprised of interventional cardiologists. But I truly believe that just like other frameworks, having a multidisciplinary team is very important because it adds different perspective that you may not have thought about. So what should be the PERT algorithm? I'm not going to go through the details, but this is our PERT algorithm. I won't go into details, but I can tell you, when we started a PERT algorithm, similar to what Barbara was saying, you need to protocolize things. And one of the things that was in our protocol, which we did not realize for a while, was if you were diagnosed with a high-risk PE, the protocol was thrombolytic therapy. So one thing we did was we said no more doing a knee-jerk reflex of saying if it is high-risk PE, you just lyse the patient. So we said that if it is a high-risk PE, unless the patients are active CPR, try to stabilize them, do a PERT team call, and we'll take it from there. And that has been very helpful in the management of patients. So this is kind of our PERT team algorithm. And just to skip in the interest of time, so we also have, it's protocolized as to what are the data elements required for a PERT consult. So in other words, the first responder, typically it is an ICU fellow, is required to collect all of these data before they get onto a call. And we have outlined responsibilities. This is the responsibility of the MICU triage intensivist, exactly what kind of information is needed. We have outlined the responsibility of the cardiology fellow, mainly to do echo, and we do advanced echo, trying to understand RV hemodynamics and maybe even calculate echo-based cardiac output. We also have responsibilities for the primary team, exactly what needs to be done. Finally, we have, after the discussion with the PERT team, disposition. So based on the classification of the PE, we say, can the patient go to a general medical ward compared to an ICU versus advanced levels of care. So the evolution of PE care is paralleling that of myocardial infarction and stroke. And just like a team-based approach has been very helpful for all of these, I feel like the PE will also largely benefit. I mean, we have clearly seen we're starting with mortalities more than that of acute MI. And I know I keep emphasizing that it's really important that we have a system-based care to drive those mortalities down. So just to summarize, why is a team-based approach important in PE? Specifically, rapid diagnosis and streamlining of care, escalation to advanced therapies, meticulous follow-up acutely and beyond. And again, be prepared for worst emergencies, and potentially we can improve outcomes. And we use our PERT team also to be part of multiple trials, and we try to enroll as many patients in clinical trials as possible. Members of the PERT team, it really depends on the composition at your hospital, but I would strongly recommend a multidisciplinary team approach. I mean, it really gives different perspective. Many a times we may feel like, hey, I know everything, I'll do everything, but really what we have learned from heart team, shock team, etc., more members are better, at least have multidisciplinary team. And PERT protocol, you should customize to what's the resources available to you, and create centers and PERT referral networks. Thank you for your attention.
Well, I think we have some time for discussion. So, I think we all highlighted the importance of approaching this complex syndrome as a collaborative team. I think I don't know, there's colleagues over there at the back. If you guys have shock teams at your institutions, I don't think many hospitals in Mexico or Latin America has already arranged a shock team. But Basir, what would you say, what would you recommend to people that are starting or wants to start a shock team at their institution that could help them regarding leadership, regarding the who should lead, who should be in the, what are the foundations that you think that the institution must look for in order to develop a good and solid team since the beginning?
Yeah, I think ultimately, we talk about shock team, it's a whole session, right? But I think maybe it's actually blown out of proportion a little bit. And people feel as if they have to get 10 people on the call for all of these cases. I think the most important utility of a shock team is to have an easy button for somebody when they are uncomfortable managing the patient, right? Because if you do feel comfortable, there is value in a multidisciplinary discussion. But that, I think, is done in a more resource-heavy environment. I think when you're struggling to take care of patients and to have man and woman power to take care of critically ill patients, it's important to kind of utilize a smaller team. And I don't think we should feel shy about that. I think, having a interventional cardiologist and an intensivist is usually enough. I think having some level of multidisciplinary discussion is helpful, but it may even be somebody within your own discipline, but just a second colleague to kind of help affirm that, hey, this is the right treatment strategy for this patient.
Yeah, I completely agree. The best way to start a team is start small and be consistent. I mean, I think the key is consistency. What we have done for all of the teams is keep the team small so that it's manageable. And I mean, you can grow as you grow, but in most of the cases, even in our shock team, there are times that we are doing an acute MI. My fellow is outside. They will activate a shock team, heart failure, whoever can get on the call. We quickly talk about it. And I mean, there are multiple different advantages to it. But again, practicality and consistency is the key.
And I mean, back at our institution, sometimes because of the medical insurance, different medical insurance for our patients, not every insurance can cover all of the devices or the cost of the devices. So, so we really need to select the patients. So I think that at our institution, one of the benefits of having a shock team is that we are selecting better the patients because it's cost effective, because it improves mortality. And another issue that has been a challenge at our institution is like creating education to early detection of shock. Because, I mean, I can present a case of a patient of 70/40 with tachycardic and a lactate of 7, but normotensive shock or patients that have hypoperfusion but normal blood pressure, these are more complex, and this has been a challenge. I don't know what has been historically in your institutions to educate and to have people aware of there is a possibility of shock in different scenarios that could benefit from early support or early management.
Well, I hope that the DORA lactate clearance actually helps a lot with that. I mean, ultimately, if you have at least somebody who is checking a lactate, then at least that is a marker that if something is elevated and it's bad, that at least you're getting some help. What happens, I think, in the United States, and I'm not sure if it's the same in Mexico, is that the majority of shock patients are in smaller community-based programs. The physicians are not in-house 24/7, and so the majority of care is being directed by nurses. The nurses then call and ask for help, and then they're blown off, right? Oh, blood pressure it was 90/60 an hour ago, and now it's 80/40. Just give another 500 cc bolus, or just start norepinephrine and call me in the morning, or whatever the ultimate treatment strategy is. But ultimately, these should all be ways for us to be able to drive the boat forward into, providing actual care that will change the trajectory of the patient.
Yeah, and I think that's critically important. I mean, just to give a quick case scenario, last week I had a patient comes in with massive elevations in his anterior lead. We take him to the cath lab. At that time, there was a lactate drawn. It was positive. Blood pressures in the 180s or 120s. So anytime I see a diastolic pressure that high, we clearly know they're trying to have, clamped up their systemic vascular resistance. They're trying to compensate. It's normotensive shock. So we do a 30-second right heart cath before revascularizing. Clearly low index, normotensive shock. So we revascularize, beautiful, and it's unlike danger, right? So this is not a patient who is in overt shock. I mean, blood pressure is high. So I get off the call, I say, let's get on a quick, after I'm done with the case, I say, let's get on a quick shock call, and I tell them, look, he's not in overt shock. This is normotensive shock, but I'm very concerned about him in the next few hours. And clearly, we said, let's make sure we follow serial lactates. 4 hours later, lactates going the wrong direction. So, that was very helpful. I mean, even though it's not a bread and butter, like systolic blood pressure less than 90 or 80 or whatever it is, right? I mean, this is a patient who came in hypertensive. So I think this is why continuity of care and like everybody being on the same page matters.
And I just want to highlight that the SkyShock meeting has a pre-com regarding the shock team, and I mean, maybe you can elaborate a little bit of what this program has been, and so people can engage and maybe develop their own shock teams in Latin America.
Yeah, I think honestly this is something that any large system really requires in terms of trying to deliver the best level care. And the conference is simple. The pre-conference happens before SkyShock. We've done it for 3 years now, and this is going to be the 4th year coming forth. And ultimately, we go through all of the nitty-gritty things, the things that aren't on everyone's slides, right? Is it really better to call 10 people at 2 a.m.? Is it better to call 2 people at 2 a.m.? Is it better to, who's the quarterback of the team? Is it an APP? Is it the doctor themselves? There's advantages and disadvantages of this, and the major thing is there's not one way to do it. If somebody, during this conference says that I have the best shock team, I know everything about management of cardiogenic shock, this is the best algorithm to use, these are the best devices to use, they're wrong, right? Jacob and the Danger team have revolutionized our understanding of cardiogenic shock just by the simple fact of did cardiac arrest happen or not, and how fundamentally that changes our perception of patient's long-term outcome.
And Dr. Bangalore, so regarding the PERTs, we presented in the last symposium, the last session regarding pulmonary embolism. So there's some data of the benefits in patients with normotensive shock or intermediate risk patients that maybe benefit from interventional therapies versus lytics. So this is a complex decision sometimes. I don't know if it depends on the institution expertise as well, or how do you guys manage in the PERT these decisions at your institution? Does the leader that it's on call gets the call and then makes a meeting with the PERT and they decide, or how does it normally work?
Yeah, and so in our case, the PERT team is typically 3 members. It's pulmonary critical care, interventional cardiology, and critical care cardiology, and that's why it's short, it's small. The first response is pulmonary critical care. So, and we have an algorithm in place that if it is low risk PE, they don't activate. Anything other than low risk PE, we get activated. And previously, pulmonary guys would give their perspective. We were looking at a different perspective. We learned a lot from each other. And now, given what we have published on CPES score, et cetera, so we are using that score. And even, there'll be times my pulmonary guys will say, the CPES score is high, it needs to go to the cath lab. So I'm the one saying, look at the CT scan. I'm like, it's a bit distal, maybe doesn't need it, et cetera. But, what has happened is we have grown, and it's been an amazing experience that we have grown. They see the improvement in outcomes of the patients, the symptomatic outcomes, the hard outcomes. We've seen it, and I think so that makes all the team members go in the same direction. So it's been amazing.
Okay, is there any question from the audience or any final comments? So I think this was a great session. I thank you very much for being here, and we'll go to the next session, which is the last one, and then everyone can enjoy the pool and the beach.